So we'll get started. Hello, everyone, and welcome officially to the 10th session of the International Deprescribing Journal Club, hosted by the US Deprescribing and Research Network. This journal club is a product of a collaboration between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and the Canadian Medication Appropriateness and Deprescribing Network. To start, we want to thank all of these groups for their efforts in collaborating with us to plan this session. I'm an assistant professor in the Department of Family Medicine at the University of Alberta. I'm completing an RCT on deprescribing antihypertensives in long-term care, and I'm a member of the Canadian Medication Appropriateness and Deprescribing Network Research Committee. We are here today because of an initiative led by different deprescribing research networks around the world. All of these groups of researchers and clinicians from different continents thought we need ways to connect and discuss ideas, recent deprescribing publications, and complex clinical cases. This is how this journal club was born. Our goal is to foster connections and collaborations, as well as to share the latest research about deprescribing. A bit of housekeeping before we get started. To help us ensure good audio quality during the speaker's presentation, please keep your microphone muted. Because not everyone is able to attend live, especially since we are living in different time zones, we will be recording these sessions. Please take note that this recording will be posted on the CADeN YouTube channel later today, and the site is listed on the slide. You can also consult this webpage to view all previous journal club sessions. And Michelle has kindly offered to share her slides, and there'll be a link to download the slides on the website listed. Now it's time to introduce our speaker. Michelle Keller is an assistant professor of gerontology, the Leonard and Sophie Davis Early Career Endowed Chair in Minority Aging at the USC Leonard Davis School of Gerontology. Her current work is focused on evaluating patient-centered deprescribing interventions for high-risk medications, such as opioids, benzodiazepines, and sleep medications in older adults. Research topics include interventions to enhance care and manage polypharmacy in under-resourced communities and for older populations facing language barriers. Michelle, if you could share your slides, that would be great.
Fantastic. Well, welcome everybody. I'm so happy to be here today. It is a true pleasure to be amongst folks who are very excited about deprescribing. I will just go ahead and share my screen and put it to presenter mode. Okay, terrific. So today we're going to be talking about how do we engage inpatient clinicians in deprescribing, and I'm going to be talking a little bit about what we learned from our implementation science research. So a little bit about me. I'm a health services researcher and trained in both epidemiology and qualitative research methods. So I do a lot of mixed methods work. I'm Mexican American. I was actually born in Mexico City and moved to the States when I was 8 years old. And so I have a deep appreciation for kind of cases where, older adults and their families are facing kind of situations where the language may not necessarily match, that of the home country. So a lot of my work, as Ronnie mentioned, is really focused on how do we actually help improve medication management in diverse older adults. I did my training at UCLA and I'm currently at USC. I'm a huge hiking fan, and so this is a quick photo of myself and my husband when we were doing some hiking in Ecuador, which if anybody's ever going there, I have some wonderful recommendations. So my research, as I really alluded to, considers how do we optimize medications in diverse older adults using this socio-ecological approach, right? I really like to think about, deprescribing and medication management at a variety of different levels. How do different policies, how do our systems, the way that our environments are set up, shape high-risk deprescribing in diverse older adults? Thinking about issues such as language and cultural barriers. How does that affect high-risk medication use? And really thinking about how do we make sure that our interventions are, actually inclusive of a variety of older adults in our communities. Today, I'm really going to be talking really about kind of these two circles, thinking about institutional, interpersonal, and individual behaviors related to deprescribing. So I want to start us off with a very common scenario, which I'm sure many of us, are familiar with. An older adult is taking one or more medications associated with high fall risk, right? Whether this is medications for sleep, an antihypertensive, right? That may not necessarily be appropriate. Older adult experiences a fall, fractures their hip, and ends up hospitalized. Um, One thing that I'm sure is very, frustrating for many of us in this world is that the older adult is typically discharged on the same medications as pre-hospitalization. And, our inpatient clinicians will say, well, this is an outpatient problem. This patient came in with these meds, not our job to change them. This will be done in the outpatient setting. That's really the assumption, right? What we found is that patients and their families may not have actually necessarily been warned about the risks of these medications, right? We all know they may have been taking these medications for many years, but now the person is older, they're more frail, their gait and balance may have changed. And so the context has changed for these medications. And there may not be necessarily discussions about their risks post-hospitalization. Everyone may be focused on dealing with the acute issue. Um, we know that oftentimes inpatient encounters actually may result in little to no discussion of high-risk medications post-discharge. And so this idea that it's an outpatient, it's kind of like, a game of hot potato, right? Everyone's like, well, it's their problem, and no one's really doing anything about it. Um, what ends up happening next, and these statistics are really focused on the US, but we know that every year about 300,000 people are hospitalized for hip fractures. 8 to 10% experience another hip fracture within 5 years, and about 30% experience mortality within 1 year. So we know that trying to prevent that next fall or that next hip fracture is really critical. And ignoring the medications that that patient is being discharged with is really actually quite a gap in terms of our evidence-based goals kind of care. So I started thinking about this issue. I've done some work in informatics and was really active in the clinical decision support, research and evaluation community at Cedars-Sinai, where I was based for many years. And we did this evaluation of how effective is clinical decision support, specifically like a pop-up alert when somebody is placing an order for a sedative hypnotic. How effective is that in actually changing clinician behavior? And this was really coming about, I'm not a clinician myself. I'm a social scientist, but having spent a lot of time with clinicians, I could just see them clicking through and quickly clicking away that pop-up and saying, okay, we're going to ignore this, right? So we actually did a formal evaluation, and we looked at, this is a Beers criteria recommendation. There's strong evidence to avoid benzodiazepines and sedatives in older adults. It lists the reasons why they may really result in adverse events. And so we wanted to know how effective was this pop-up. So we actually looked at both the inpatient and outpatient setting, but I'm going to be focused on the inpatient setting right now. So we looked at about nearly 5,000 alerts triggered in the hospital. We found, to maybe no surprise to many folks, that providers were ignoring or overriding about 97% of the computer alerts. Most of the alerts were completely ignored, so a clinician was able to just click through and just click cancel and make the alert go away. Or they would just decide to keep the order and cancel and just ignore the alert, which and I think part of this reason was the initial idea for the alert is, well, if we remind somebody that these medications are not good for them or they're not good for the patient, surely they will do something about it, right? But I think what really for us, for our research team, we really understood was these medications are these are outpatient medications. They sometimes are used in the inpatient setting. That is true. And that is possibly why in some cases they're used, for example, to make sure that a patient is not anxious about a particular imaging scan or whatnot, right? But in many cases, these were just the free text comments. So this only includes, many of these canceled or overridden alerts may have been for this reason. Many of the clinicians were saying, look, the patient's already on this medication. It's chronic use. It's a home med, long-term use. I'm not dealing with it. I'm going to click the alert away. And so it really brought us to this idea that if you want to try to change any sort of prescribing behavior in the inpatient setting, this isn't about knowledge. Clinicians know that these medications may not be ideal for older adults. It's not a knowledge problem. There are many other factors that are at play here. And that's how we really started thinking about this idea of how do we use implementation science to try to change physician or clinician behavior, I should say. So that's what we thought about. How do we use implementation strategies or implementation science to develop these strategies to deprescribe these medications in the hospital? So, many of you may already be familiar with implementation science, but I always like to just kind of give a broad overview. It's a scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research. So thinking about the Behaviour's criteria, we know these medications are not great in older, there's strong evidence that they should be avoided in older adults. However, many of the older adults are still taking these medications. So how do we bridge the gap between research and practice? And specifically, we wanted to focus on, I should say clinician. I keep on saying physician, but it's really clinician behavior, because as I'm going to be talking about in the rest of this presentation, we actually engaged a variety of different clinicians to help us think about this issue, because we really think it's a team-based approach. Our thought was, what are the barriers and facilitators to begin deprescribing benzodiazepines and other sedatives in the hospital setting? We conceptualized kind of hospitalization as this potential reachable moment. There's been some fantastic work on smoking cessation where, it's the kind of thing where maybe it's not a one-time discussion. There may be a variety of different discussions that need to be had before that message really sinks in. And this is an excellent kind of, analogy to that, right? It might not necessarily be that medication is immediately started, the tapering has started right at that moment, but can we actually even begin conversations about deprescribing, particularly when that person has experienced some sort of issue related to, that may have led to their fall that's related to the medications they're taking. And the idea really is, how do we build theory-based interventions that build upon these facilitators and directly address the barriers, right? So addressing really thinking about this as a mechanistic approach to designing interventions. So we really focused on using these two models, and folks who are familiar with the behavior change wheel will immediately recognize these. These are the capability, opportunity, and behavior model and its extension, the theoretical domain framework. The idea with these models is that we need really three major components. Capability, we need to know about the problem. We need to know what to do about the problem. We need to have the motivation to actually do something, and we need the opportunity. So, these behavior change frameworks can be used for all sorts of things. I'm thinking of as we're coming to the new year, New Year's resolutions, right? You may know that you maybe need to cut back on your nightly glass of wine, but maybe you don't have the motivation to do it, right? You need these three ingredients in order to be able to change behavior. And the theoretical domains framework actually really parses these three components into kind of more specific types of, for example, you might not just need to know, about the risks of these medications. You need to know how to begin tapering them, right? Or for a clinician, you need to know what that tapering schedule might look like and how you might actually have these complex conversations about deprescribing. So these two frameworks can be really, really helpful in helping us identify what are the potential gaps in terms of what we're seeing with the behavior we want versus the behavior that we're currently witnessing. And as I mentioned, so this is part of a larger implementation, really a method for characterizing and designing behavior change interventions used called the behavior change wheel by a researcher, and I'm blanking on how to exactly pronounce her name, but I believe it's Mickey. And the idea is with the behavior change wheel is that we have a diagnosis phase. We have to figure out what is happening. In our case, why are clinicians not engaging in deprescribing conversations? We know from the clinical decision support alerts, it's not a lack of knowledge, right? They're getting these alerts all the time. So the question is, what is happening in terms of, that next step? Then we use that information to design an intervention. We really target the exact kind of changes, the gaps, and we build on those facilitators to design the intervention, and then we implement and deliver that intervention. So I'm really going to be talking mostly about the diagnosis and design phase today. So what we did was we did some qualitative interviews with clinicians, and we focused on pharmacists, nurses, and hospitalists to try to identify implementation barriers to deprescribing. Lucky for us, this study happened during COVID, and I say lucky in a very sarcastic way because it was very challenging to try to get clinicians to engage with us during this time because they were very busy doing other things like a global pandemic. So we had a lot of phone calls with them as they were heading home from work or to work in the car. And that's how we did our qualitative interviews. So if anybody has ever some thoughts on like how do we really recruit clinicians in challenging times for qualitative interviews, I'm happy to commiserate with you. Um, what we did was we interviewed our clinicians, and then we used these two frameworks to actually code the qualitative data. And then what we also did is we did what is called member checking. We went back to we have a working group of physician, nurse, and pharmacist collaborators. And we went back and we said, does this resonate with you? Are there things that you feel like you want to add in terms of some of these findings to make sure that we really had covered this whole kind of all the potential issues that we could be finding. So what did we find? We found that so when speaking to nurses, many of them were aware that these medications were potentially inappropriate for older adults, but they didn't really know how to potentially convey the risks of these medications to patients. They didn't feel like they had the capability necessarily. And in some cases, they didn't feel like it was actually part of their job. They felt like this is the physician's job or the pharmacist's job, even though they, in many cases, were the ones giving the medications to patients, they didn't feel like it was their role to necessarily question which medications were being given. There are also amongst our physicians and nurses also lack of knowledge about how to engage in these complex conversations about deprescribing. As we in this deprescribing world know, it's not really, you're suddenly kind of taking someone who has been taking a medication for, let's say, 20 years, and you're all of a sudden having them question whether this is a good medication for them or not. And that can be quite complex and emotionally charged, which leads us to this issue about high levels of resistance and anxiety among patients deprescribe. Some clinicians told us about, examples where they had decided to talk to a patient about it, and the patient had reacted very badly. And in particular, if the patient didn't feel like the reason they were in the hospital was connected to the medication, they get even more upset because they were like, well, I'm here for, this reason. Why are you talking to me about my medications? So there was already some pessimism about from our clinicians. And so that really was inhibiting their motivation. There's also the obvious issue of opportunity. There are competing tasks in the inpatient setting, right? Person fractures their hip, they may need surgery. This needs to be the most important task, and the medications may fall to the wayside. And then there was some concerns about post-discharge follow-up, right? Like, let's say we have this conversation or we begin tapering the medication. What next? That was certainly a concern, and incredibly valid concerns, I think, all of these. And that's why I think any intervention really needs to consider a lot of these issues. So I want to kind of go through a couple of quotes. Or actually, first, I'll jump to a few facilitators. Amongst some of our clinicians, our pharmacists and physicians, very well versed in the risks of these medications. They were very much aware, and this goes back to our inpatient clinical decision support findings. People know, they're well aware that these medications are not appropriate for patients. They also found that there are opportunities to identify these medications, right? It could be through rounds, through huddles. There were opportunities to discuss these in an interprofessional manner. And they did find that if they could make the connection between the medication and the reason for the hospitalization, and they could make that connection to the patient, and that was more obvious, that there was some potential to actually be able to do the deprescribing. So I'm going to just take us through a few quotes of what we found. So here, a nurse, who is really talking about pessimism and negative outcome expectancy, she's talking about patients who are on scheduled benzodiazepines, right? They're taking these multiple times per day. And she said the scheduled ones are just no interest, no interest. I think they're so set on their schedule. Like, I came here for a fractured ankle. I'm not leaving here with like new, she's like, just fix my ankle. I'm doing what I've done this whole time. Certainly very valid, in terms of somebody who does not want their medication this question, particularly something that's not being changed or prescribed in the hospital. Another nurse, we asked her, do you feel comfortable educating patients and their caregivers about the fall risks of some of these medications? The nurse answers, no, I never bring it up individually. I'm very general about it. Yeah, I'm just not the physician. It doesn't feel right for me to do it. I know that I don't know enough about the medications, like scientifically about the meds, to explain it to them and to answer more questions that they may have. So this speaks to potentially a lack of knowledge and a perceived lack of self-efficacy or confidence in discussing these medications, right? Another one might be emotion that I mentioned before, right? A pharmacist says a lot of the family members are shocked. Sometimes they get offended because they don't want to be accused of not taking great care of their family member because they thought that this was the best care. So, certainly, and this goes to the complexity of these conversations in terms of memory, attention, and decision processes. In other words, like, what else is going on in the situation, right? In the inpatient setting, there's something acute going. Often at times it's not related to the benzo. So we're often focused on that. And it's different than in the outpatient setting, where there's sometimes sort of discuss some of these chronic issues and chronic medications that patients are on and what they need it for and how we can better manage that. So I think it is a challenge. And then additional concerns that were identified by our pharmacist, physician, and nursing work group. During COVID, staffing was quite challenging. There were particularly nursing staffing, many travel nurses. So, a challenge in terms of, even if you were to implement something during this time, you may not have, the people you trained better. That's always going to be a challenge because there may be a lot of turnover. There were also concerns from our nurses about, if a patient makes a complaint about, somebody is harassing them about their medication, it may go back to nursing management, and they were very concerned about that. From our pharmacist leaders, there was this thought about how in the inpatient setting, pharmacists are often trained to consider inpatient medications. And so they're very focused on acute issues and they don't want to mess with the home medications. There were also concerns about patients leaving against medical advice because they were upset. And then these were really, I think, quite thoughtful around issues around patients being judged for these medications, right? In some places, they may not disclose during the hospitalization that they take these medications actually quite regularly. They might say, I take it every once in a while when it's more than once in a while, right? And so they may feel judged by clinicians about their use. And so a variety of incredibly valid concerns, and really helped us kind of really think about the complexity of just even having these conversations about these medications in the inpatient setting. And now I want to talk about kind of some steps in the behavior change wheel, how we go about thinking of how we're going to potentially change some of this clinician behavior. So first, kind of one of after we kind of diagnose the issue, it's really about identifying what are some broad categories of things that one can do to change behavior? And what we did, and this is part of the method, and if you're interested, there's a wonderful book called The Behavior Change Wheel that really has all these ways that you can map. You diagnose your barriers and facilitators using the theoretical domains framework, and then you map them on. And I'm going to give you some examples of intervention functions that are aimed at changing behavior. And these are very broad. They can be applied to any sort of behavior change that, we're trying to do. So for example, we might have training. Let's say that our nurses are not feeling necessarily capable about discussing these medications. We might think about imparting skills to increase physical and psychological capability and beliefs about capabilities. Right. We see this a lot, for example, in terms of, let's say a hospital unit is trying to, let's say a surgical team is trying to improve turnover time. They might create incentives, right? If we reduce turnover time, like 5 days in a row, we get a pizza party, right? There's like an incentive, goal setting, a variety of different ways in which we can broadly change behavior. And I was driving in Los Angeles, as we often do, and I came across this billboard, and I wanted to show it as an example of a intervention function focused on persuasion. Right? It's aimed at kind of eliciting a strong emotion. Right? You love your kids, make sure they're in the back seat. Right? What it's really telling you is if you don't if you don't care about your kids, put them wherever. But if you love your kids, you're going to do the right thing. This is a very clear example of a behavior change technique being used to make sure that the parents are placing their kids in the correct seat, during while they're driving. So these behavior change techniques are being used on us all the time. Now the way is, how do we harness them to kind of motivate the behavior change that we're looking to kind of engage, or that we're looking to kind of have clinicians do for our particular setting. And then we think about once we've thought about, let's say we're like, well, we're going to use persuasion and we're going to use education. We're going to use these broad categories. Now we think about the behavior change techniques. These are irreducible, observable, replicable components of an intervention designed to change behavior. So for example, and there's a wonderful, I will, as our moderator mentioned, I will have my slides posted, but there's a wonderful website here called Theory and Technique Tool from humanbehaviorchange.org that actually lists all the different types of behavior change techniques that can be used, and it maps them to a variety of different types of intervention functions and barriers. So when you're designing an intervention, you can actually look through these and identify which are really going to address the barriers that you are experiencing. Behavior change techniques, as I mentioned, might be like the discrete, let's say, for example, there's a goal within a primary care clinic to make sure that all of the patients get a cancer screening, right? Like, let's say a colorectal cancer screening. We might have a dashboard, and that might be a specific behavior change technique. And we might review that dashboard every single week to make sure, is every single patient getting their a reminder about their colorectal cancer screening. And so the active ingredients in our intervention. What we did to identify these behavior change techniques is, again, we took our interdisciplinary work group and we sat down and we said, these are the barriers. How do we go about actually overcoming some of these barriers based on the behavior change technique literature? And so we kind of sat down and we started thinking about, we could use persuasion, right? There are ways in which we could try to evoke a negative emotion or a positive emotion in somebody. But there are potentially other ways that are already used in the healthcare field. So for example, a demonstration of the behavior, right? So maybe somebody having a role play conversation of what a complex deprescribing conversation might look like. We might align it with existing institutional goals, right? In the United States, as in many other places, there's a strong goal to try to reduce readmissions. If we're trying to reduce readmissions and we know that medications are related to readmissions, we might say, look, the deprescribing conversation, that's part of this goal. We have to kind of build it in to the work that we're doing. We might focus on problem solving. So if a family gets really upset, what do we do? What do we make sure that we, what are some ways in which we can think ahead of time of like how we might actually make that family not feel judged about the medications that they're giving, that they're, kind of administering to their family member. So we really focused on these three as the ones that we thought would be the most powerful and the most kind of feasible to implement within the hospital. And last is really thinking about how are you going to deliver this intervention. So in the case that I showed you earlier of the image of the kid in the back seat, like they were like, well, we're going to put a billboard on a bus sign so everyone driving by sees it, right? Like you're driving, you're thinking about it, like your kid may be somewhere. It's like it's a way of making sure that it fits with whatever is kind of happening in this person's mind, right? So how does it align with existing organizational goals? How does it align with staffing, define roles, and training? For example, we would not ask a nurse to change a medication order because that's not within their role, right? Like their role may be to administer the medications and have discussions with the patient about medications, but we're not asking them to change their outpatient meds because that's not that's not aligning with defined roles. So that's a really important consideration is that whatever you're trying to do has to fit, right? These already, you can't kind of try to completely reinvent things. And so what we did with our interdisciplinary work group was we sat down and we thought, how could we actually help our clinicians make these changes? One way was really we knew that there was concerns that if the patients had, if they were upset with the clinician who was like let's say a nurse goes and talks to the patient about their medications and that makes it back up to nursing leadership. We knew we had to have nursing leadership involved, right? And in fact, the message ideally would come from nursing leadership that the role of the nurse in this unit is to increase patient safety. Patient safety is already a pretty important goal for our nurses, and that includes educating patients about medications. This is actually part of your job. So really addressing that barrier that we saw earlier where someone's like, I don't think it's part of my role actually. We're like, no, it is. It is really part of your role because you're giving, when a patient is like, oh, like, hey, I couldn't sleep last night. Can I have my regular benzodiazepine? I would like to take it. Maybe it is really the role to actually have that discussion about how, maybe this is actually potentially leading to your next fall. We also were thinking about how do we add objects to the environment to make these conversations easier? And this is where, we have some fantastic materials from Choosing Wisely, from deprescribing.org. I think about the Empower brochures, right? These materials have already been designed to already change patient behavior. So why not use those in the inpatient setting? And importantly, because we know that sometimes the inpatient setting is a time with a lot of overwhelm, if we're making sure that they're provided to patients so that they can access them later. So maybe they're provided in, their discharge paperwork, particularly if it's in the patient portal so they don't lose it on the car ride home, right? Maybe making sure many of our pharmacists make post-discharge phone calls. And so they might go over the materials with these patients and ensuring that these are communicated to patients in a variety of different languages. And lastly, we thought this idea of modeling. How do we help clinicians have better conversations about deprescribing, developing strategies for managing patients who are hesitant, thinking about what we've learned from other interventions, where we really debrief together. And so this was something that people were very excited about, in terms of really thinking about integrating things like action planning, problem solving, and demonstrating the behavior. So the next step was thinking about what is the affordability of this particular intervention? How practical is it? Is it going to be effective? Is it going to be acceptable to our target audience? What might be some side effects? and make sure it's equitable. So for example, if we were to use the Empower brochures, making sure that they're available in a variety of different languages, right? Which I know that they've been translated into, so but making sure that they're available so that nurses can deliver them to patients in the correct language. And we asked our stakeholders, we asked our working group to sit down and really think about which of these interventions could potentially work in our setting, and maybe how might we need to tweak them to make them maybe more feasible, more cost effective, and acceptable. What we found was that potentially, even though we love this idea of an interprofessional seminar series, we were like, the scheduling challenges are going to be like crazy. That's going to be very difficult. But what we could do is we could focus the intervention on nurses. We could involve senior nursing leadership, and we could really empower nurses to have these conversations with patients with, again, things like the role playing, modeling the behavior, action planning, problem solving, right? We also, one of the thoughts that our pharmacists had was, if we intervene on our highest risk patients and we're able to track outcomes, we can show, hopefully, that the deprescribing actually maybe does work. And if obviously we know that it's challenging to show outcomes in deprescribing, but at least if we're able to kind of, let's say, have an anecdote of a patient who, they were feeling more alert and they were feeling better, right? Like, we know that that storytelling is very powerful to people. And so providing that outcome back to teams to kind of reduce some of that pessimism and that negative outcome expectancy. And lastly, we really love this idea of distributing materials to patients. It helps to guide the deprescribing conversation with training, obviously. So it's not just handing a brochure to a patient, right? The idea is that the person who is giving this brochure to the patient has a thoughtful conversation that's been planned out. And the idea is, we may not always be able to start the deprescribing in the hospital, but at least we're raising some awareness of the fact that some of these patients may be taking medications that they just didn't know that what the risks might be. So what are our next steps? Our next steps, we want to try to pilot these interventions in one unit. Our thought was, one of the things that, as I mentioned earlier, one of our facilitators was, can we tie the medications to the reason the person is in the hospital? So let's say the person is there for a fracture, many of which are caused by falls. Can we then make that more direct connection? So we're thinking of partnering with our geriatric fracture unit and training the nurses there. I'm thinking about a small pragmatic feasibility trial of implementing our various interventions, the nurse and seminar series, using the patient deprescribing. So these, and really thinking about our highest risk patients. So in this way, we can kind of try to reduce the number of patients that people have to talk to. We're not feeling like we're adding a ton of work overload, but we're really targeting the intervention and then using some of these existing materials for our patients. And another one of our thoughts is, we really want to engage patients and their families in this work, right? So what happens when we do bring these conversations to patients? What do they think? How do they feel about the way that the materials are being presented, and how could we improve our intervention? And our eventual goal is to do kind of a larger randomized control trial. So with that, I will end, and I'm more than happy to take questions. I want to thank the US Deprescribing Network US Deprescribing Research Network for all of their support and work. It's been a wonderful, really a wonderful opportunity to be part of the research network, and for our International Journal Club to be able to talk about these issues. I'm going to actually, this is my old email address. I just realized I didn't change it, but I do still have access to it. I'll put my current email address in the chat. I did leave Twitter, sadly, because it was getting a little crazy, but I am on Blue Sky. So if folks want to follow me or connect with me there. So I'm going to go ahead and stop sharing, and more than happy to take some questions.
Yeah, Michelle, thank you for your very insightful and informative presentation. I'm going to be downloading your presentation because it's going to be helpful for my next research project. So I will start off with questions. As a family physician, I find that transitions of care is very challenging. In Canada, there's a lack of family physicians as well. It may take time for the patient to actually book in to see you. And even if you do see the patient in a timely manner, you may not know what exactly is happening and the deep prescribing that happened and what you should be doing. But do you have any suggestions for this?
Yeah, absolutely. I think one of the things that we found was that so we did an outpatient intervention where we used the Empower materials for benzodiazepines and other sedative hypnotics. And it was very interesting because that's an area where we also realized we had to engage our outpatient providers. Some of them were not really sold on the concept of deprescribing, and that took some effort, right? And so what we realized was really effective was if we can get the patient on board with the deprescribing, we have solved that's a major hurdle because oftentimes in the outpatient side, there's a hesitation to begin the deprescribing for many of the same reasons, right? Like people are not convinced that it's going to work. They're afraid of having that tricky conversation with the patient. And so getting the patient and their family involved can help to at least alleviate some of the issues you discussed in terms of thinking about, so for example, let's say the patient may not see their physician for a few weeks. That we definitely don't want them to go cold turkey on their medications, right? Particularly something like a benzodiazepine, I think that's why it's so critical for the conversation to be very thoughtful and to be like, your next step is to go and talk to your family, physician. If that takes 6 weeks, that's okay, but we encourage you to bring these materials with you so you can talk about them with your physician and, potentially even bringing some of the, in an ideal world with connected electronic health records, we can send a message to the family physician telling them, hey, we talked to your patient about deprescribing, they are considering it. Here are some tapering schedules, or here are some extra resources that we might actually encourage you to use, or you might want to use. And so I think we really kind of focused on how do we use these conversations to have our patient and their family be that in our very fragmented systems. We are relying on them, unfortunately, to kind of be that barrier between the inpatient and outpatient setting. And I think our pharmacists can help as well. But it's absolutely an issue. Patients may not see their primary care physician right away. They may not mention it to their primary care physician. So if there's some way to communicate that through an electronic health record note or through an email address, there was a study, and I am of course, blanking on I will think of it, but there was a fantastic study actually that they did look at a hospital and deprescribing. What they did, which was very smart, is they looked at patients who were being discharged to a skilled nursing facility. And so those patients had more follow-up, right? So they were able to start the deprescribing during the hospitalization. Then they followed up with the skilled nursing facility. And so the deprescribing could actually continue during that time. And what was really interesting was that in that study, they actually contacted the primary care physician. They made phone calls, and we all know that it can be tough. Family physicians are very busy, but they were able to connect with the family physician and make sure that the person was on board. And so that was really it's a great, I think, a really good example of how everybody many of our clinicians really want the same thing. It's just about getting the process started, having that really tricky, convincing the patient and their family that this is necessary. So I think that's I think really important. But to your point, we definitely are going to have some of these barriers around transitions of care in the best circumstances where we will have some discontinuation between what's happening in the inpatient setting and outpatient setting. I think that'll continue to be an issue.
Thanks. And just a reminder, to ask questions, you could either enter your question in chat or even raise your hand if you would like to ask a question verbally. And we have a question in chat. I'll just read it out. And actually, first, Camille, do you have a question?
Oh, you could start by reading that one and I'll go right after because Rajneesh's question came first.
Sounds good. If a clinician has had a past bad experience when deprescribing, for example, the patient died, then the clinician will be reluctant in the future to deprescribe. How do we address this issue? Perhaps counseling for the clinician?
I think that's absolutely, I mean, that's an incredibly like challenging adverse outcome that could be, happening to, for that clinician, right? Absolutely, really devastating to have a patient die due to an action. What I will note is that, we often know that the flip side happens, right? That the patient may die because they are continued on that medication. Let me answer your question first. I think absolutely. I think support from, other clinicians, particularly maybe somebody who is, really identified as a champion in that area and who could really say, who could really offer some support to that clinician about how that deprescribing issue was really tied to, the death of that patient, really trying to understand, like, was it really just this particular deprescribing issue? Were there other things going on? Really trying to kind of get at that issue. That's obviously going to be incredibly challenging to address with that particular clinician. But I think, yes, to your point, like counseling, social support from the rest of, kind of the deprescribing community or deprescribing champions, I think will be really critical. What I will say to the flip side of that scenario, where the patient dies because they are still taking the medication, there was some work that was done by one of my colleagues at University of Southern California, Jason Doctor, where they sent letters after a patient had overdosed on opioids. They actually sent letters to the patient's physician saying, hey, your patient actually overdosed on opioids and died. And you were the prescriber. And that intervention, I mean, I think it's a little intense. But that intervention also shows the flip side of not deprescribing, right? We know there are a lot of adverse effects associated with these medications. And so I think some of these situations, there's a cost to not acting as well. But I think it's a great question. I mean, it's always really tricky, and I think making any sort of decision or not decision can have consequences, and recognizing those are really important.
I can follow up. Yeah, thank you. Thanks and congrats on the great presentation. Loved hearing about this work. I wondered if, and I'm sorry if you mentioned that, as part of the themes that were brought up by the clinicians that you interviewed, as a barrier, and well, I mean, in terms of the work I work at the Canadian Medication Appropriateness and Deprescribing Network. We promote, of course, deprescribing. We often hear, well, we don't have access to those non-farm approaches that would help support deprescribing. Is that something that was mentioned by the clinicians? And do you believe it could have been less mentioned because we're in an acute setting and it's less part of the preoccupations of and maybe the second, like a twofold question, were there also concerns about switching to other therapies, medical pharmacotherapies that would have been, as inappropriate?
Yeah, to your first point, I think it's exactly right, where because they're focused on more of the acute setting, I think they're not necessarily thinking about, well, we could offer the patient like cognitive behavioral therapy, right? Or something, right? They were like, well, we can't, I don't know if that's our job. What I will say, which was really interesting, was that our interviewees actually mentioned some of the ways in which they tried to reduce kind of benzodiazepine and sedative use in the hospital. For example, like the hospital has these like, smart speakers. And so they would try to have relaxing music for the patient. There's been a patient team that's been created, like a sleep kit where they give you a little eye mask and some aromatherapy, trying to actually address this issue in the inpatient setting. And so there's been some real creativity around problem solving these issues in the inpatient setting, with with not like, not a ton of resources, right? Like, I mean, the smart speakers maybe, but certainly that could be done something on a patient's cell phone. They could turn on some relaxing music. The idea, I think, to me was there wasn't as much of a concern. Yeah, they didn't raise it as much because they were like, look, we're trying to problem solve here with what we have. Like, we don't have access to like counselors necessarily who can come talk to our patient. So this is what we're trying to do, which I thought was really interesting. So they were even kind of thinking about alternative ways. And remind me of your second question.
Yeah, I wondered if they were, in terms of barriers there, they could have mentioned concerns that later down the line, another therapy for insomnia or anxiety could be initiated and with, similar level of risk.
Absolutely. We did have patients or some of our clinicians discuss, for example, sometimes where a switch might be made to like like a gabapentin or something, right? Oh, it's like, but I think this is where I think like in our case, we found that clinicians were pretty aware of the fact that many of these medications were already quite sedating. Like it wasn't the knowledge. We didn't see that like at least amongst our physicians and pharmacists, they knew that there were already this group of medications. They were they knew about the Beers criteria. They were aware that there were these groups of potentially inappropriate medications. The question was just like, when should the deprescribing begin? And that's where they were like, I don't know if it's should be inpatient or, so I think there were fewer concerns about switching it to another medication. And part of it, again, could be that they're in the acute setting, right? So they're not thinking long term. They're not like, well, if the medication is substituted, it's kind of like not their problem at that point, right? Like they're like, that happens down the line. But certainly they were pretty aware. And I'll give you an example. One of our nurses mentioned for her, it was one of the reasons she really tried to dissuade patients from taking, let's say they were already on a benzodiazepine or taking an Ambien or a Z drug on a regular basis. She really tried to talk to the patients and say, I don't want you to take this because the next day I'm gonna have a really hard time making sure that you walk around and get up and get around the hospital. And that's really important to your recovery, right? Like it's my job to make sure that you get out of here safely and you are healthy. And so it was kind of like I think they were really trying to push these non-pharmacological options because for them it actually changes their job as well, right? Like they can't get the patient out of bed if they ask for a substitution of the medication and it's equally sedating. So there was definitely a recognition that switching to another med might not necessarily be the answer. But again, we are limited in the sense that they're not thinking long term. They're thinking, how do we get this patient discharged in the next few days safely and they don't fall in the hospital and then we've moved on, right? But yeah, really great questions.
Great. Wait maybe a minute or two to see if anyone else has any questions. And while we're waiting, I have another question in regard to your intervention. It seems like it's primarily nurse focused.
Yes.
Why did you decide to do it nurse focused, and what's the role of like clinician and pharmacist as well?
Yeah, that's such a great point. So we really honed in on dressing or really engaging and empowering nurses for a few reasons. One, they're the ones spending the most time with a patient. They are the ones who are monitoring kind of for things like alertness and sedation. They have kind of of course, we see, our physicians are checking in and they're doing their rounds, and our pharmacists will come and talk to the patients during discharge. But we thought, one of the things that we know it's very important in deprescribing is the establishment of rapport, right? There has to be some sort of trust. And that's difficult to do in a hospital setting, particularly when you see maybe the physician for a short period of time. And so we thought, who best has the opportunity to actually establish some rapport with a patient than someone who's regularly checking in on them, and, gets to know them and their family a little bit better. That's another thing in terms of like, the family may not be there every single time the pharmacist comes by or the physician comes by, but the nurses may be more likely, so we can engage kind of more folks. And so that was, I think, our thinking was Oh, and lastly, the nurses are often ones administering the medications. And so they may not be prescribing, but they are the ones kind of giving the patients their medications. And so we thought this is a good time maybe to have that conversation as they're like, oh, here's your medication. Let me tell you a little bit about, some experiences I have and some thoughts. And so that was really where we kind of thought about how do we engage a group of clinicians who we think really could effectively connect with a patient in a variety of ways. So yeah, it's interesting. We also thought changing physician behavior was going to be one of the hardest things to do. I'm going to be honest. So we were like, maybe we'll try something else first.
Yeah, that makes sense. And
It looks like we have one more question potentially.
yes, if you want to go ahead, Rajneesh.
Can you hear me?
Yes.
Hi, Michelle. Thank you for answering my question earlier about the clinician having counselling. I just thought I'll put it out there because I don't want it to be like a shameful or a taboo thing for a clinician to, have counselling because they're supposed to be able to look after themselves. But I wanted to ask, I've been looking at, I'm not a healthcare professional, but I've been looking at the world of deep prescribing for a couple of years now. And it's the same issues of, the clinicians are, very busy. Deep prescribing is not at the top of the agenda. So I was wondering, like, what does everybody here think of like a service where, like a separate service for deep prescribing, which, perhaps a patient can be referred to, and then that individual who's the healthcare professional in that service would then, specifically look at just that deep prescribing, because it may be that because deep prescribing is such a complex issue, it's not just about medication. They might need to speak to a counselor. They might need to have social prescribing done. They might need other things done before you get to the medication. That it may be feasible to have like that sort of service, which is specifically for deep prescribing.
Yeah, absolutely. And I am going to do a shout out to some of my pharmacist colleagues actually who developed just that. They developed a deep prescribing clinic, and this one is specifically focused on, and I'm going to see if I can find it in my a deep prescribing clinic specifically focused, and it was exactly, I think, addressing your issues, right? Like there is a need for a lot of handholding, a lot of support. And so there was a recognition, and this is in the outpatient setting, I should say. And so I think that's obviously, something where it's a little bit different, but it was really this recognition that it's really tricky to do this, over long term. Everybody is busy. Everybody is trying to deal with some other, the patient is dealing with 5 different chronic issues. Their diabetes is uncontrolled, and deep prescribing often files to the wayside. And so there's, I think, often, I think it's an amazing idea, and certainly something that we've implemented within this health system. Obviously the tricky thing is it just has to be, you have to think about how you're going to pay for that, right? Like how is someone ensuring that health system sees the value of it? Because a pharmacist, in this case, it's a pharmacist run deep prescribing clinic. The pharmacist is expensive to the health system. So I think it has to be a health system that recognizes the value of that, which, we're all trying to do with our showing things like outcomes. So absolutely, I think that's really critical. And I can't find the article right just now, but I will I'll post it on Blue Sky. You can find it there. But absolutely, I think that to me that's the dream, right? Like how do we create a clinic where there is time and expertise in really being able to address these deep prescribing issues. And so we lift that burden off of everybody else who's really kind of struggling in this very busy system. Absolutely.
Yeah, thanks. Yeah, I would love that too. We have around a minute left or so, so we're just going to launch our final poll just to see if the session met your needs. If you could answer the 3 questions that pop up on the screen, we would really appreciate it. And thank you again for attending this session. Thank you, Michelle, for your excellent presentation. And we hope to see you all at our next session. We don't have a date set yet, but it will be either February or March.
Well, thank you so much for having me. It was such a pleasure. Great questions, and I hope to be I hope to join the March session as well.